Only mode.
Hello, all. Good morning. Welcome to the Cushing Support and Research Foundation Quality of Life webinar. We are so happy that you all could join us today. I'm joining from San Francisco, where it's 9 a.m., but we have people from all over the world joining us, and I thank you for coming and being interested. As most of you know, this is a presentation from the Cushing Support and Research Foundation. We have a ton of resources out there on our website, and I really encourage you to go to csrf.net to see what resources we have and find the information that you need. And you'll also find on our site a way to contact us if you have more questions. Very quickly, I wanted to just introduce myself. My name is Alyssa Klein. I'm one of the directors of the Cushing's Support and Research Foundation. I'm also a Cushing's patient. I had surgery in 2004, so I can relate to what a lot of you have experienced. Our other directors are also Cushing's patients. I want to also introduce our sponsor. So this program was generously funded by an unrestricted educational grant from Strongbridge Biopharma. And we thank them so much for their support. Now I want to introduce our presenter, Dr. Susan Webb. Dr. Susan Webb is a full professor at the Department of Medicine at the Autonomous University of Barcelona. She has over 35 years of clinical experience in endocrinology. In particular, she mostly sees pituitary patients. She's the leader of a clinical research group on pituitary diseases, and she is joining us from Spain. In addition, her research group is the coordinator of the European Register on Cushing's Syndrome, Cushing, which includes partners from 50 centers in 28 countries, and after 7 years contains data on over 1,000 patients. Her research interests lie in pituitary diseases, and particularly in Cushing's and acromegaly, and she's very experienced in quality of life issues for all Cushing's patients, both ones with active disease and patients who have a surgical cure. So without further ado, I would like to hand over the presentation to Dr. Susan Webb, and I hope that everybody is able to see what's going on. And if you do have any questions during this presentation, you can enter them, type them in, and I'll do my best to help you out during the presentation. So let me hand this over to Dr. Webb.
Okay, can you see the slides now?
Yes, we can see your slides.
Okay, fine. Well, good morning to every one of you. Good afternoon. For me, it's 6 o'clock in the afternoon here. I'm really pleased to be in this webinar, and I hope it'll be useful for some of you. I have prepared this thinking that you are patients, but if it is too technical or above your head or there's something that I don't explain well enough, please let me know and I'll try to explain it later in the discussion. what I'm going to talk about today is the long-term outcome in adult patients after a diagnosis and often treatment of Cushing syndrome. And of course, the first thing we have to remember is that Cushing's does create a lot of symptoms. And I'm briefly going to go over how frequent these symptoms are, also whether they resolve following successful treatment, and many of them, as we will see, determine the patient's everyday quality of life. This slide, whoops, wait a minute, what's happened here? Well, I'm sorry, I can't see the graph that should be here. I don't quite know what's happened because I could see it on my computer before. But anyway, this was a graph which showed the distribution of symptoms in the overall European Registry of Cushing's patients, which included in 2014 nearly 1,200 patients. You should be seeing some vertical bars, but fortunately the text down at the bottom gives you the main message, and that is that 81% of the patients have weight gain, 75% have hypertension at some moment or other, 72% have skin alterations, and by that I mean skin thinning, bruising, ulcerations after a minimum, let's say, erosion or whatever. Myopathy, that refers to the patient's muscle atrophy, so that the patients feel really tired and the muscles sort of wear out very quickly when you try to do some exercise. Hirsutism, that refers to, in women, the growth of hair, which is unwanted or abnormal, say on the body or the face, in 58% of the problems, of the cases, and these were the most frequent symptoms. However, being a registry, you don't always get all the answers. For some questions, the information was not known. For example, reduced libido was present in quite a percentage of patients, but in 63%, that is in the majority, this problem was not answered. That means that often this is something that is not talked about or not discussed in the medical consultation, so that when you fill up the registry, you just don't have the data available. And I think this graph, taken from a publication in a surgical journal, in Surgery in 2008, is very representative of what happens after normalizing cortisol. In this case, these were patients who had undergone a bilateral adrenalectomy, that is, both adrenal glands had been taken away, so their cortisol practically had disappeared from their body. This means that they must take every day hydrocortisone, because if not, you would die, because you can't live without cortisol. But it also means that all the problems related to the excess of cortisol, which is typical of Cushing's, would disappear overnight after surgery. But as you can see here on the left, on your, well, on say on my left, I hope it's your left, you can see here that it takes more than 6 months on average for menstrual problems to recover, for the purple stria on the skin to improve, hypertension to improve, the round moon face, easy bruising, again the facial obesity and central obesity. So it doesn't happen immediately after surgery, even though you may find improvements, but things don't disappear overnight. Things like the excess fat on the back of your neck, known as buffalo hump, or depression, or the excess body hair, takes on average more than 9 months to disappear, and diabetes can take also 9 or 10 months. One thing that patients often complain about, despite being, let's say, cured, is that they're weak. That is, that they start doing some exercise or even the housework or gardening or just walking, and they feel tired very easily. And this goes on, as you can see, on average for a year at least after surgery. And hyperpigmentation, that is the skin being darker than it usually would be, that is due to some hormone abnormalities, this can also take more than a year to recover. So this is just telling us that recovery after surgery takes time. And even though what has been doing all the damage was the excess cortisol, the body sort of gets used to it. And in a way, it would be, and please, this is just a comparison, right? But if you have a drug addict who's on heroin and you suddenly take away the heroin, he will feel dreadful. He will have a deprivation of that drug. In unoperated Cushing patients, you often find that immediately after surgery, for the first weeks or the first months, the patients feel worse than ever. And in a way, it's because their body is noting that lack of cortisol, which is what we were really looking for, because the high cortisol was creating all the problems. But that change is something that does have impact on the patient for several weeks or even several months. And then, of course, when you say endocrine, you're cured, all your hormones are normal, but things don't always go back to normal. There are residual problems even in patients who have been successfully treated with surgery, and there are residual problems, mainly impaired health-related quality of life. And as we will see at the end, in the last 3 or 4 years, there have been several studies which have shown that there are some very subtle, that is, small brain abnormalities observed, both on MRI scans, so these would represent morphological or structural abnormalities of the brain, but also in the functioning of the brain. That is, difficulties with memory and some cognitive dysfunction. And I'll come back to that and explain what I mean. When you look up, and I looked up in the Collins English Dictionary for the definition of cognition, it says it's the mental act or process by which knowledge is acquired, including perception, intuition, and reasoning. It's also defined as the knowledge that results from such an act or process. And words which are considered synonymous would be perception, reasoning, understanding, intelligence, awareness, insight, comprehension, apprehension, and discernment. So as I said, there are some subtle cognitive problems, even in cured Cushing patients. So there may be some problems in any of these words or even any of these issues which are mentioned on this slide. Okay, but let's go back to quality of life. Quality of life is something that only you patients really know about, because we physicians or health professionals really can only know what you tell us, because quality of life is something which is subjective. Only the patient knows, and it reflects both the disease and its therapies, But of course, your quality of life, not your health-related quality of life, but your quality of life as a general can be affected by many other things. Family issues, financial issues, personal issues, etc. But of course, I can't really talk about that. What I'm going to talk about is health-related quality of life. And you can see on this slide, what I try to represent is that we have subjective and objective issues which affect quality of life. And things like hobbies, professional activity, symptoms you may have or certain deficiencies, libido, and even the patient's humor all affect quality of life. So there are social dimensions, there are physical dimensions, and there are psychological dimensions which all end up determining your quality of life. As I said then, health-related quality of life is defined from the patient's perspective, and it relates to how one feels, functions, and responds in daily life. It is influenced by personal goals, expectations, standards, concerns, even cultural context, because it is easy to imagine that some issues may be very important in one country, but not in another, or in one continent or not in another. And, of course, life events. And then there's a very important thing we must remember, and we will come back to it at the end, and that is adaptation. If one feels a disability, for example, if it is painful to walk, you will try not to run the marathon because you will have a dreadful time. So you will either find ways of controlling that pain or you will walk very little. So to maintain a good quality of life, if you have a series of medical or physical problems, you will tend usually to take up activities or challenges that are within your capabilities. As I said before, quality of life reflects overall effects of both the disease and its treatment, and as far as how you can evaluate quality of life, this is usually done with questionnaires. And there are basically two types of questionnaires. Those that are called generic and those that are called disease-specific or disease-generated. Both have advantages and disadvantages. The generic questionnaires can be applied to any normal population or any disease group. So if you want to compare quality of life of patients with arthropathy or with cancer or with kidney stones or with Cushing's, you would use a generic questionnaire because then you can see whether the scores are worse or better in one disease group or another. However, these generic questionnaires are less specific if you want to see a change, say with therapy, in a specific disease. And in that case, it is better, if you have one available, to use a disease-specific quality of life questionnaire because it approaches those problems which are typical of that disease. So just before we go on to discuss this a bit further, I just wanted to recall that when we talk about health-related quality of life, we refer to a concept which reflects physical, functional, social, and emotional well-being of an individual. The results are oriented to the patient, and this is done to establish the best treatment option, obviously together with blood tests, x-rays, and many other things. So a quality of life result can be used in clinical decision-making by health professionals, but they can also be used in pharmacoeconomic studies, that is, trying to see whether one treatment or one attitude towards a determined disease is better or worse or more expensive or cheaper. And so it can be used in pharmacoeconomy, and then usually it's used in this cost-utility analysis, and you may have heard about QALYs, which stand for Quality Adjusted Life Years. But in the end, what everybody is interested in is increasing both the quality and the length of someone's life, let's say. So here we have again what I was mentioning before. On the one side, the generic questionnaires, and there are many, but these are some which are often used in clinical medicine. One is the Nottingham Health Profile, the other one is the Psychological General Wellbeing Scale. There is the EuroQol, which has 5 dimensions, of which you are asked whether you have any problems, serious problems or no problems, and then it also has a visual analog scale, which is like a thermometer, and then you are asked to say if you consider that your quality of life today is fantastic, that would be 100, or it's absolutely dreadful and you're about to die, and that would be 0. And between that, you can then, well, establish where you think your quality of life is. And then another generic questionnaire is the SF36, which stands for short form 36. But as I say, if we do have a disease-specific questionnaire, then it is more sensitive to observe changes. And for Cushing's, there is the Cushing Qual, which stands for Cushing Quality of Life Questionnaire. And as you can see, there are a series of other disease-specific questionnaires for pituitary diseases, one for acromegaly called AcroQual, and then for growth hormone deficiency, there are a couple. One is called the AGDA, and the other one is the QLS-H. This I talked about briefly before, the advantages and disadvantages of a disease-specific quality of life questionnaire versus a generic questionnaire. Of course, a disease-specific questionnaire can only be applied to patients with that disease. So you cannot compare the health status between different populations or diseases, even though usually you can come around that by giving both a generic and a disease-specific questionnaire to the patients. So then you have the issues which are related to that disease, and that also can allow you to evaluate that patient's quality of life in comparison to normal population or other groups. As I say, disease-specific questionnaire is designed for a particular population, in this case Cushing's, and it measures those dimensions which are more relevant for that target population and is more sensitive to change, benefits of treatment, and can evaluate better differences in health status. And here we see results from the Netherlands. And you can see here with the NHP, which is the Nottingham Health Profile, and with the short form 36, general perceived health in patients with cured Cushing's, and those are the orange bars, and in healthy controls in blue. And for the Nottingham Health Profile, higher is worse. So patients cured from Cushing's, and these were patients that on average had been cured for 13 years, had more energy problems. You can see down here, more pain, more emotional reactions, worse sleep, less physical ability, and more social isolation than the normal population. And with the SF36, here, lower is worse. And again, you can see how with this other questionnaire, all these items here, which are physical functioning, social functioning, role physical, role emotional, pain, general health, and health change, are all lower than in the normal population. Let me remind you, these are patients who had been cured for an average of 13 years. So this just is telling us that not everything went back to pre-Cushing status. So this is telling us that Cushing's syndrome has a significant impact on health-related quality of life, despite long-term cure. So patients do experience issues with quality of life, with both physical and psychosocial limitations, and this is especially so in the presence of hypopituitarism. That is, if patients with a pituitary Cushing's have undergone pituitary surgery and some of the other hormones of the pituitary are also or have been touched during surgery and are deficient, then quality of life is also more affected. Okay, but how does quality of life compare at diagnosis and after treatment of Cushing's syndrome? Well, here are some studies, and these were some that we performed in Barcelona, where we looked at quality of life in patients who came to us as new patients because they had been recently diagnosed. And then we evaluated them again 4 to 6 months and 9 to 12 months after surgery. And we administered a generic questionnaire, the Euroqual Visual Analog Scale, which is this thermometer I was telling you about, and then the Cushing Qual questionnaire. And as you can see, compared to baseline, at 4 months, there was a small increase in the Euroqual, which actually was significant statistically at 9 months. So there was an improvement. If you look at the Cushing Qual questionnaire, it was at baseline 41 out of a maximum of 100. At 4 months, it was 54. And at 9 months, 9 to 12 months, it was 68. But being more specific, it was already statistically significantly better at 4 months than at 9 months. So this means that after surgery, things definitely do improve. However, when we looked at the 5 dimensions, which are included in the generic Euroqual 5D, standing for 5 dimensions, you can see in the columns here, in white, the cured Cushing patients, compared with patients with active disease. You can see that the white columns, that is the cured patients, did better after cure in mobility, self-care, usual activities, and anxiety and depression. But for pain and discomfort, they're actually, well, it wasn't significantly different, but they were the same or if not worse. And this actually has an explanation, because many of you may know that glucocorticoids are given in some clinical situations for patients, for example, with severe arthritis and in other inflammatory diseases, because cortisol is a very strong anti-inflammatory drug. And of course, when Cushing's was active, inflammation was reduced, but then once you have been operated on, your levels come down, and then sometimes your pain gets worse. And that's what I was saying, the first few weeks or months after surgery, sometimes you feel much worse than you did before. And as you can see, pain did not improve in these patients. Oh, this is really a real nuisance because, again, I don't know what's happened to these slides because I could see them perfectly well on my presentation before. But anyway, this slide,
Dr. Webb, you might want to exit the slideshow view, and then we might be able to see the entire slide.
Press what?
Exit the slideshow.
Exit this one?
Yeah, just exit slideshow mode.
Oh, I see, but then they'll be smaller. That doesn't matter?
Well, let's see what it looks like.
Oh, no, there's something wrong. I don't know what's happened here because I could perfectly see them before. I can see it here. Look, there it is. I don't know, because I can see it here small, but I don't know what's happened. Anyway, it's not too serious because I can explain it.
Okay, you should go back into the slideshow then.
Fortunately. Okay, I will. So here we are. These were data from the Cushing, that is the European Registry of Cushing's Syndrome, and the line here showed the Cushing call, the visual analog scale, that was the thermometer, from baseline, and then 3 up to 12, up to 24 months, and more than 24 months after surgery. And what we could see was there was a steady improvement of this scale after surgery, demonstrating again then the quality of life does improve. This one we can see, which is okay. This one is the Cushing Qual score, again, baseline and up to 3 months, then up to 12 months, up from 12 to 24 months and more than 24 months. And you can see after surgery, and you can see how, again, there is a definite improvement with time, but it doesn't happen immediately. And then when we look at the different dimensions which are included in the Cushing Qual questionnaire, you can see in the same way how wound healing does improve, as does easy bruising. You can't see, but sleep also improves. You look long enough, say after 12 and 24 months, does improve. And hopefully we can see, okay, irritability does improve, physical appearance does improve, daily activity does improve, but unfortunately you can't see, but you can imagine that memory just stays the same. It does not improve despite 2 years with normal cortisol. And that is something that often you will have perceived, and when you ask patients, they do say that their memory is worse now than it was before. And which are then the factors which affect quality of life in patients with Cushing's syndrome? Well, I've put them together here, and all these can impair quality of life in Cushing patients. Active disease, so the situation is worse in active disease than in cured disease. The need for medical therapy. The need for frequent checkups also. The fatigue and weakness that is experimented despite being cured. Issues related to physical appearance. Obviously, if your body has changed completely, you have put on weight, your face has changed, this definitely impacts your quality of life. And even though things can improve, they may not be normalized, or you may find that you look different than you did before. Emotional lability. This is something which is often mentioned by the patients. As I said, cognitive problems, some depressive symptoms, sleeping difficulties, and as I mentioned, in the pituitary-dependent Cushing's, if the rest of your pituitary doesn't work very well, that can also affect negatively your quality of life. And the situation of being adrenal deficient in the first few months or years after surgery can also negatively affect your quality of life. This is another way of looking at this, and you can see here in pink psychological dimensions and in yellow physical dimensions which affect quality of life. We will see some repeated, like emotional lability, depression, anxiety, low sexual desire, altered body image, cognitive impairments, mainly memory, and altered or abnormal personality traits. On the physical side, we see joint pains, muscle weakness, active hypercortisolism, obesity, hypopituitarism, adrenal insufficiency, some abnormalities in the brain white matter, which we will come back later, and also sort of shrinking of certain parts of the cerebellum, which is the posterior part of the brain. And I want to share with you this email. Those of you who don't speak Spanish, don't worry, I'm going to translate it for you. It was sent to me by a university professor who had adrenal Cushing syndrome in 1995. And this was the time in 2006 when we were developing the Cushing Qual questionnaire, and we needed patients who had Cushing's to validate the questionnaire. And I met her at a meeting, and I said, listen, we're doing this questionnaire. Would you be willing to be one of the persons who fills it in? And she said, oh, yes, no problem. So this is the email I received when she sent the questionnaire back. And she said, dear Susan, I've just sent by courier the questionnaire and the informed consent, both filled and signed. I thought the questionnaire was quite good and very complete. Said, it's incredible. I thought I was doing you a favor, which she definitely was. But then she said, it's been the contrary. It has been very useful for me because it has allowed me to know the reason why I have some problems, and especially it has made me recognize that I have them and that I can improve them. This has given me a lot of peace, energy, and hope. I hope that you're successful with the questionnaire and that all that is reflected in it will improve the quality of life of those like me who, being considered healthy, have what one could name as a bad iron health. If you need anything else, you know where I am. So I can't hear you and I can't see you, but I can imagine that many of you may have believed that this also affects them in many ways. So what can we say then? That health-related quality of life is severely affected in Cushing syndrome, that it does improve after successful therapy, but it often does not normalize completely despite endocrine cure of the disease. And now I'd like to go to some results of the brain studies which have been carried out in the last 5 or 6 years. And there have been several groups around the world who independently all seem to have come to similar conclusions. Here you can see the brain with the sort of the gray matter, and which is on the surface, and then the white matter, which is under the surface. The pituitary would be here, and this here at the back is the cerebellum, and here you would see the brainstem. And I'd like to quote this systematic review. This means that all literature available have been searched for, analyzed, and put together to try and see what was known about this by different investigators, because as you all know, Cushing's is rather rare, so it's very difficult for one center to have enough experience to put together hundreds of patients. And this was this systematic review on the effect of Cushing's syndrome on the human brain, looking both at structural abnormalities, that is, when you look at an MRI or some imaging, that you can see there are some very subtle abnormalities, but also functional, and this is where I refer to cognition and other psychological issues. And the main conclusions were that patients with active disease, this can affect their brain structures and does determine certain abnormalities in some of the chemicals which determine brain function. All these abnormalities tend to improve after cure, but may not be completely reversible once cortisol normalizes, even years after remission. And these structural abnormalities can be related to certain behavioral problems like cognitive and emotional functioning, mood, and quality of life. And what are the psychological issues in cured Cushing's? Well, I've said already several times, many patients experiment impaired memory and difficulties in what is called executive functions, despite being cured for a long time. They're more apathetic. They get irritable more easily. They have this sort of emotional ability that your humor goes up and down without any apparent reason, and a greater tendency to become depressed or more anxiety. When you specifically use psychological testing, it has been shown that these cured Cushing patients have a slower learning process than before. That is, and please, I mean, sometimes we get questions, does this mean I have Alzheimer's? No way, not at all. Please I want to make this extremely clear. It's just that if you do these psychological testing, you find that cured Cushing patients as a group have a slower, let's say, functioning than people who haven't had Cushing's, but it doesn't mean that often that their results are below normal. They're just within the normal range, but slightly lower. And as I said, less memory. And it's also sometimes difficult to maintain attention, to maintain concentration for a long period of time. And this slide here is just to show how in patients, if you compare one and the other top X-rays, I think you will see that on this center image there is more black than and there's more white on the image on the right. And this is just showing that there is certain shrinkage in patients with active disease. You can also see it here. This structure here, which is the cerebellum, is smaller than this other one. And this is the same patient prior to and after therapy. And you could do the same showing patients and controls. And you would see that patients with active Cushing's do have these sort of brain shrinking, which does recover, at least in an important part, after hormones get better. And with psychological testing in Cushing patients, both in active and in cured Cushing patients, you can demonstrate they have a worse visual perception. Certain activities which require fine motor skills are also slower in Cushing patients and controls. There may be some language difficulties in the sense that you can't find the word you want at the right moment, or if you're asked to say 10 words that start with a determined letter or say the names of 10 animals, patients who've had Cushing's take a little bit longer than patients who have not had Cushing's. Also, as I mentioned before, executive function and information processing speed and cognitive functions. So basically memory and executive functions. And as I say, this happens in Cushing's syndrome more than in normal controls. Patients also feel more fatigued and find it difficult to maintain attention for a long time and have a greater tendency for depression and anxiety, more mood disorders, impaired stress perception, and a negative affectivity. Results do improve after control, but may still remain below, let's say, the normal average values for the general population. So, bad quality of life does improve in remitted Cushing's, both of pituitary and adrenal origin. It seems here that the bad guy is the high level of cortisol. So whether it's due to a pituitary-dependent adenoma or an adrenal cause, or even an ectopic cause, the results here are all very similar. But may not return to pre-Cushing state, as I said, suggesting the toxic effect of the prior glucocorticoid exposure. And cognition may not recover completely in cured Cushing's and explains these residual complaints of bad memory, irritability, apathy, anxiety, depression, and bad affectivity. But then, of course, you say, well, you've been telling us all about these things, and what about me? Can I improve things? Because I've had Cushing's, and that's nobody's fault, that just happened. But can I improve things? And the answer is definitely yes. It's not necessarily going to be easy, but things can definitely improve. And just knowing that this occurs and understanding why you're having these difficulties and why it persists, I think already helps. It's important to be realistic, not to think that you can do things that really are beyond you at this moment. Because being realistic is encouraging, as knowledge can make a very positive difference in coping with post-Cushing's issues. And please, do not blame yourself. You're not stupid. You're not a person who can't carry out her work anymore. I mean, you do have perhaps some limitations, but that doesn't mean that that's the end. No way. There is no magic formula which works for everybody. If there were, that would be very easy. But we're all different, and things that work for one may not work for another. Psychological help may identify if a problem does exist, for example, depression, or if you're really having attentional deficiencies that you can't really maintain attention, can't concentrate, and you have memory problems. Because if you identify these problems, then, well, some may have a specific treatment which may improve then the whole situation. And sometimes we get asked, well, which is the best drug for depression? Well, there have been no clinical trials to demonstrate which drug is better than another, but there are some data which do seem to indicate that drugs like fluoxetine, which is an SSRI or selective serotonin reuptake inhibitor, may be the drug to start with in cases of depression. And I think it's interesting to remember the psychological process of adaptation, which is something that we all do throughout life. But let's just remember the 5 phases and how this can apply to Cushing's. In the first phase, you're getting health problems, you don't know what's happening, there's uncertainty and confusion. The second phase usually coincides with diagnosis, and then you are bewildered and you have negation of you just deny the problem. The third phase, you have opposition and you may feel isolated. The fourth phase, you react, and you sometimes can react with a rage. And then the fifth phase is sadness. And here it is important, because if sadness continues and nothing is done, it can lead to depression. But often, sadness can then take one to adapt to the situation, the new situation, and this is much easier to adapt if you're positive about things. So, what would be the example of Cushing syndrome? In the first phase, prior to diagnosis, you probably experiment fear, anxiety, uncertainty. Nobody understands me, they don't listen to me. At diagnosis, initially, there's a sensation of relief. Ah, finally I know what's happening. But then there are new anxieties and needs. You have to look for expert professionals. You have to have access to these professionals. but also to the required tests and to the therapies. It is important to get reliable information. Internet is fantastic, but sometimes the information you get is not really the best. And here it's where relief funds like the Cushing, the CSRF, is really very important, because they do have information which can help you. And also, it's not only on the disease itself and therapies, but legal issues, like if you are too tired to work full-time, can you take up part-time? And there are many things which can be helpful for the individual patient. And look for support beyond the endocrine care. For example, to confront and to improve the quality of life issues. Once you've had Cushing's, you have to confront the situation. You have to live with Cushing's, obviously. You will try to get the hormones normalized with adequate treatment. This sometimes is easier than other times. Sometimes after surgery, your hormones go back to normal, but other times, you require 2 or 3 treatments, or even after being cured for a number of years, your Cushing can come back. And then you have to go through all this again, which is definitely not something nice, but it may occur. Obviously, understanding by your environment, be it the family or your working environment, your friends, is important. So talking to them, telling them what you have, is not a bad idea most of the time, because if they know that you'll feel so weak, and the moment you go out and you start walking, you just feel so exhausted. If they understand this, well, they will probably be understanding and help you more. And I think it is really important to share experiences with other patients, because they are the experts. They know what they have gone through. And the support groups here can be a tremendous help. You aren't alone. You're not the only person going through this. And sharing experiences is usually very helpful. So a message of hope is really important. This isn't the end. There are other diseases which unfortunately are the end. This is not the end, but you will probably have to adapt and change a few things. And as I said, being positive definitely helps. I would suggest that you take the reins of your life. Don't blame yourself or others. I mean, this has happened and you can't do anything to make it disappear. And so you won't gain much by blaming yourself or others. And with any situation in life, you can't always get what you want or avoid any pain and suffering, but you can definitely improve things. It is important to try to keep an open attitude towards changes you may have to do, avoid unrealistic decisions, and try to get involved in new projects. And I think that's all that I had prepared, but I really will be happy now to take questions and answers. And this is a beautiful field in the spring up in the mountains in the Pyrenees, which is very relaxing, and I'm sure that many of you will enjoy going out into the open, especially in the spring, even though we're going towards the autumn now. But anyway, there are also some nice places to go to in the autumn. So I think I'll leave it there and give it back to you, Eliza.
Hi, Dr. Webb, you have a couple of questions assigned to you. The questions panel.
Okay, what do I do now then?
Can you open up the questions panel? It's in your one of the sections in the control panel.
Okay. Just wait a minute. Ooh. Questions. Which one is that? I can see. Let's see. Is it at the side or is it at the bottom?
It's towards the bottom. It's one of the sections in the control panel.
Oh, yes, the questions here. It must be, okay, fine. Okay, how long, right, this one, the one of Roseanne Odum? Is that it?
Yes.
Okay. How long are residuals present? I've been recovered since my surgery in 1997. Well, as I showed you at the beginning, some things take longer than others. Some may not recover completely. In other words, if before having Cushing's in 1997, you could go on a hike and climb mountains, you may not be able to do it now. And since 1997, that's what, 18 years later, you're also a bit older by now, and this may not recover. So muscle atrophy does get better, but the capacity to do physical activity is something which may not recover completely. And as I said, the memory problems also tend to be there for a very long time. And once you get sort of beyond the age of 55, 60, your memory does begin to go down just normally, just with aging. So it may not go back to what it was before. Okay, I'll go to the next one. I had cyclical adrenal Cushing's and had surgery, okay, a year and a half ago, January 2014. The doctors removed my adrenal tumor and left adrenal gland. I'm still weaning off steroids, and my right adrenal is giving signs of waking up. At this point, what do I do to reach wellness, to help heal the damage of my body and address the emotional psychological syndrome? Is there anything I can do to improve my memory and stamina? Right. If the other adrenal is beginning to wake up, that's good news. As soon as you can stop taking the steroid replacement therapy, fine, but you might try and find that you are just still too weak and you still need a low dose of hydrocortisone or whatever cortisone you're taking in the morning. Things will get slowly better, but as I've been saying, most of the time, things may not recover completely. The last few slides I put up, especially thinking of this, because sometimes, as I say, patients are told, oh, once you're operated, you'll be fine. And as you can see, it's not always so. Things do get better, but stamina and what else did you say? Stamina and the cycle and the emotional, psychological symptoms sometimes do take time. It might be a good idea if you have the possibility of getting a psychological assessment, just to make sure if your problem is depression or whether it is attentional deficit or memory, because then usually psychologists can then give you some attitude or some small everyday exercises you can do which can help you with these processes. I'll go to the next one. In the first few months following a surgical cure, in my case bilateral adrenalectomy, what hormones and biochemical levels are important to check? Can some of these being off affect how well you are feeling in recovery? Okay, if you've had a bilateral adrenalectomy, that means all the tissue in your body that produces glucocorticoids has been taken away. So you must take your hydrocortisone or whatever drug you're taking daily and regularly. And it is important to remember that in the normal body, cortisol is highest just before you wake up in the morning, and then slowly goes down over the day and is minimum sort of 11 p.m. midnight, and then slowly rises again in the morning. If you have no adrenals, the first thing you must do on waking in the morning is take your hydrocortisone, because until you've taken it and after a quarter of an hour, 20 minutes, your levels are extremely low. And then you must take another lower dose or 1 or 2 other lower doses throughout the day. I mean, it can sometimes be, and I'm always talking about hydrocortisone because that's the drug we usually use, but some patients may be on prednisone or some other drug. But anyway, I'll talk about hydrocortisone. We usually give 10 milligrams in the morning, and then 5 milligrams at lunchtime, and 5 milligrams sort of in the afternoon. But you don't need a dose at night because your levels will usually be lower, except if you're going out to dinner and going to go to bed very, very late, then you might need a little bit of an extra dose that evening before you go out, just not to feel absolutely exhausted when the others are still partying, right? Okay, the other question. How does menopause affect the pre-existing cognitive deficits of Cushing's? Well, some women go through menopause and practically don't have any problems, perhaps a few sweats and a few hot flashes. Other women have more problems. We must think that if menopause occurs sort of in the 50s, our brains are already beginning to feel that we're not 30-year-olds when we're 50-year-olds. So I think it's more sort of the normal aging process which makes us forget names or forget things that we used to remember when we were younger, more than the menopause itself. But obviously, menopause in some women is associated with a bit of depression or anxiety. And of course, Cushing's does that too. So if you have two things at a time, well, things can be a little bit worse. This takes me to think that, or to mention that aging, let's say, having been exposed to cortisol, in a way, is determining after a number of years that you sort of get some of the phenomena which are usual in normal aging. What do I mean? As I say, the memory problems, you may have more hypertension, you may have more obesity, and all these are things which usually are more frequent in, say, 70-year-olds and 60-year-olds than in 30-year-olds. So, in a way, one could say that the normal issues that happen with normal aging in a patient who's had Cushing's may occur a few years before. And those may be some of the symptoms that one may feel. Okay, are there any more? Oh, yes, many. Okay, fine. Another one. I have had significantly increased joint stiffness since surgery. I'm still taking 7.5 milligrams hydrocortisone per day. Is this normal? Can this improve? Yeah, well, I did mention this, that glucocorticoids are really very good as anti-inflammatory drugs. And of course, when your cortisol comes down after surgery, your joints don't like it. The joint stiffness can improve. I mean, if you increase your steroids, this would improve, but obviously this is not something you will want to do. So here it's sort of keeping a balance between the minimum hydrocortisone necessary and making the joint stiffness bearable. At the same time, I would advise that you keep active. I mean, just walking normally or swimming, just nothing extraordinary. Obviously, this depends on your age and how fit you are. But, you know, even though you are a bit stiff, do keep active. Again, I mean, I myself was much more flexible 2 decades ago than I am now. And this morning I was playing tennis, and I can tell you by lunchtime I was a bit stiff. And I definitely was not as stiff a few years ago. But there we are. That's life. Okay. Do you have any recommendations to help me with fatigue and tiredness? Right. Well, I think I've already mentioned it a few times. It depends how long after Cushing's, after having surgery, this is still occurring. you have to come to a compromise. I mean, not because of your fatigue, stop doing any exercise, because that makes the muscles even more atrophied. So keep as active as you possibly can. If you do have pain, well, you may have to take some painkiller, not every day, but as you need it, especially if you have a more strenuous day, just to keep you going. But again, you know, that doesn't mean you should take a painkiller every day. And the tiredness. Well, if you realize that you need extra sleep, you may have to take a nap during the day and just have a longer time in bed in the evening. I mean, I don't have any miracle drug that will take your muscles back to normal, but anyway, remember that muscles work better if one uses them. So even if they do have certain difficulty, try to keep as active as you possibly can. Another one. Will I be more susceptible to Alzheimer's as I age? Also, thank you for this webinar. Well, as I already said, no way. Alzheimer's has absolutely nothing to do with Cushing's. Alzheimer's is dementia, which is due to a specific deposit of some abnormal tissue on the brain. And that, in the end, well, makes that the brain doesn't work. So Cushing's has absolutely nothing to do with Alzheimer's, right? And, well, thank you very much for your comment on the webinar. I'm glad you found it interesting. Okay, another one. Thank you. What specific sorts of therapy, speech, pathology, psychology are most useful? Physical rehabilitation. Well, that depends what your problem is. I mean, if you are finding difficulty, say, with everyday activities, you may need some physical rehabilitation, or if you have a specific pain, say, in your knee or your shoulder or your elbow. And then as far as psychological rehabilitation or evaluation, again, it depends what your problem is. I mean, what problems you're experiencing. I mean, it's very difficult without some psychological evaluation by a specialist to know whether your problem is that you can't really concentrate, or that you just have bad memory, or if you're just depressed. Because if someone is depressed, one finds it's very difficult to concentrate and to be positive, and when one is depressed, one has more pain. So that is when perhaps a psychological evaluation can be good to identify what is the main problem. And then, depending on what the problem is, well, either give a drug or some special, let's say, day-to-day exercises, or if some people feel that they can't go out because they just feel too weak, well, if you one day just go out to the front door, the next day you walk to the corner, the next day you go to the shop, and slowly sort of build up on it. I mean, it really depends on each patient and in each subject, and for exactly what problem you may have. Okay, we have another question here. Is reduction of libido reported more with women, men, or is there no difference? Can anything be done? Well, worse libido is, I'm trying to think if it was reported more in men or in women. You know, I can't quite remember at the moment from the Cushing data, and we couldn't see the slide, unfortunately. And in many instances, this was missing. Let me say that a man with active Cushing's usually has erectile dysfunction apart from having low libido, because he just feels so awful and painful and depressed and so on. And in women, I don't think there are any studies where libido has been studied extensively and data can compare both sexes. I honestly think this is something that hasn't been done. What is known is that is very frequent, especially in the active phase, for both sexes to refer reduced libido and difficulties in keeping up with normal sex life. Obviously, this can improve once you feel better, because, I mean, obviously, if you're feeling ill for any reason, or you're physically not well, or you're depressed, or you're anxious, this is not the best situation to have a successful sex life. But having said that, what can be done? Again, here, it would be important to get some specialist assessment to try to identify what the problem is, and then depending on what is affected, well, do whatever the sexologist would suggest, and making sure that if you have other issues like depression or severe pain, this can be treated also, because it also affects your sex life. Okay, oh, we have lots of questions here. Okay, I had bilateral adrenalectomy in 2012. I'm on Cortef, okay, for the rest of my life. What are the side effects, or are there any of being on steroids for a long time? Right, well, obviously being on steroids when your body produces it, we always say try to get off them as soon as possible. But in your case, if you stop steroids, you'll die in a few days. So you cannot, because we cannot live without steroids. We need steroids every day. So having said that, it is important that you have steroids in your handbag, at work, in the different houses you may go to when you go on holiday, because you can't be without them. And also, remember that if you have an operation, you have a tooth out, you have the flu and your temperature shoots up, or you have any other illness, you must increase your dose, because the body usually does that. It produces more cortisone when you are ill. And so it is important that you increase the dose when you have some intercurrent illness. And also, it is recommendable, in case you have gastroenteritis and you are throwing up, or you have diarrhea, and then despite taking the drug, your Cortef, you find that, well, the body cannot use it because it's been eliminated. It is really recommendable to have an injection of hydrocortisone at home, because if you administer that injection, that will keep you covered for the next 12 hours, and it allows you to arrive in good shape in the emergency room, because if you don't take it, and then, well, you might have to have an emergency admittance to the emergency room, and then you will have to have fluids and IV hydrocortisone, etc. Side effects, well, in your case, you just need to take it. So I would say the minimum you can take, the better. Having said that, people who've had Cushing's and who require steroids because of bilateral adrenalectomy, or because their adrenal axis is still sort of inhibited, it has been shown that the lower the dose, the better for the bone. That is, high steroids in Cushing's do affect the bone and favor osteoporosis. And in women or men who've had Cushing's and still require glucocorticoids, osteoporosis may be an issue. So I would suggest that if you haven't had an evaluation, it may be a good idea for your bones to be looked at. And if you do have osteoporosis and you have to continue taking steroids, as you will, then perhaps evaluate the necessity of starting treatment to prevent osteoporosis to go on much, get worse. Okay, 2 questions, please. Can I expect that the longer you are out from pituitary surgery, the less chance there is that the tumor will return? I'm 5 years out. If the tumor grows back, does that mean that it will automatically cause Cushing's disease? Yes, you're right in the sense that the longer the better, but it's no absolute security that it won't recur. It is more frequent within the first 5 years, but it may occur at any time. So if it does return, it will usually return, if it was pituitary origin, which I believe it was, it will return in the same way. And I must say that on the whole, when I've seen patients who've recurred, they usually even know before the hormones begin to rise that something is not right. They somehow feel that things are coming back. And I must say they are 99% right, that things are coming back. So if you feel fine, great. If you have doubts of whether some of the symptoms are coming back, some of the feelings that you had before are coming back, I would suggest you go to your doctor and get it worked out, because the sooner it is treated, the better. Right, okay, and then, are there any studies of effect on lifespan with Cushing's? Right. Back in the 1950s, so that's what, 65 years ago, when there really was no treatment for Cushing's, 50% of the patients died within 5 years. Fortunately, the picture now is quite different. We have effective surgical techniques, we have drugs, and now things are much better. There is, when you compare patients who have had Cushing's and with normal population, and in this respect there is a very, very good Danish study which was published in 2013, because in Denmark, the moment you are born, you're given a social security number, and then anything related to health when is reported. So they have extremely good registries to be able to check what has happened to anybody in the country, and so they can look up patients who've had Cushing's syndrome over the last 30 years and compare it with the normal population. And they do find that, especially in patients who remain active, who do not normalize their cortisol despite many treatments, that their lifespan is slightly shorter than the normal population. If you are cured, then your lifespan tends to normalize. But remember that you may have a series of new problems, like I mentioned before, osteoporosis, and you may have more greater cardiovascular risk. So it is important to try to reduce this. And how can you improve your cardiovascular risk? Well, if you have high blood pressure, controlling your blood pressure, reduce the intake of salt, which will reduce your blood pressure. If you have high lipid levels, then, well, consider treating these lipid levels as you would do in other diseases. For example, in diabetes, there is also an increased cardiovascular risk. And in these cases, what they do is to treat most patients with Lipitor or some other lipid-reducing drug. So those would be my recommendations. Have a healthy life, try to maintain regular exercise, as normal as possible body weight, lipids, blood pressure, look at your bones. Those are the things that I would say. Okay, let's see. Also, HGH seems to make me tired. Will this go away? I'm not quite sure what HGH means. It's not human growth hormone, is it?
Yeah, I think that's what he means.
Okay, right. Seems to make me tired. Well, usually when you have growth hormone deficiency, that definitely makes you tired. Once you, if the tiredness is due to that growth hormone deficiency, then usually when you substitute with growth hormone, that tiredness improves. Of course, you can be tired for many things, and if you are tired due to other reasons than the growth hormone deficiency, then usually your tiredness will not improve. But if you do have growth hormone deficiency, then substitution growth hormone should improve your tiredness. What can family and partners do to support recovering Cushing patients? Well, in the first place, know what it's all about and realize that if you're more weak and you're more tired, well, you may have to stay in bed later or go to bed as soon as you get home in the evening because you're just much more tired than if you hadn't had Cushing's. I think it is important for your environment to learn, as you have learned, what Cushing means. And here the Cushing Patient Association can be very helpful, providing information and also contacting with other patients or other families who've gone through this, and then they can share with you some of their experiences. What level of cortisol is necessary to start to discontinue the hydrocortisone? Aha. Okay, well, usually if your cortisol is undetectable, obviously you have to be on hydrocortisone. Once your cortisol begins to reach the normal levels, and it's difficult here to give a normal value because there are so many methods of measuring cortisol. But if your morning cortisol begins, especially when you see that there's a change over time, perhaps after surgery it was completely undetectable, 6 months later it begins to be detectable, 1 year later it's already beginning to rise, but it still doesn't reach the normal value, then you can usually start reducing the dose. And then what I would suggest that if you are feeling normal, you're not sort of feverish or being ill, you may try to reduce the dose, say at a weekend when you're at home, and see how you feel. But don't think that because you've stopped it, you will automatically be without it for the rest of the time. You may have to go back onto dose, let's say, or slightly higher dose if you have reduced it. So it's sort of trial and error, but remembering that you comes back, but if a patient has had an adrenalectomy, that is, they don't have pituitary Cushing's, but they have adrenal Cushing's, it usually takes longer for it to recover. Okay. If there are complications after pituitary surgery, such as CSF leak and adrenal crisis that cause metabolic brain damage, will it take significantly longer to recover? My pituitary tumor was removed 2 years ago. With complications, I still struggle quite a bit with the residual problems. Yeah. Problem with a CSF leak is that sometimes it means that you can get an infection. And if you had an adrenal crisis, probably means that you did not receive enough steroids at that time. Well, after 2 years, you can still improve. So I would say that obviously this was unfortunate, but there we are. You can't blame yourself. You can't blame everybody. This happened. So I would say definitely things can improve still. And so don't lose hope. Feel positive, and perhaps you can take on some other activities you didn't do before, and that may help. When is a good time to attempt pregnancy or egg freezing after surgery? Aha, that's a good question. This is something we have just been reviewing, and it is obviously not a good idea to become pregnant when cortisol is high, because this is bad for the mother and bad for the child. Once cortisol is normalized, or even if you are adrenal insufficient, then pregnancies usually tend to be okay. I think it is important that you feel physically well enough to go through pregnancy, because you're feeling absolutely exhausted and have to spend more than 12 hours a day in bed. It's probably not the best thing to go ahead and go through pregnancy. However, if you feel, let's say, more or less well. You carry on normal life, perhaps not as active as you did before, and you are definitely not hypercortisolemic, that is, your cortisol is not high, then I think it could be, it would be a good time to consider pregnancy. Let's see, what else? Oh, was that the last question?
Well, I think I'm going to reserve a question. Can you maybe talk a little bit about why some people seem worse than others? And I know, and I just want to put this out there for everybody here that many people after Cushing's return quite to normal, feel good and normal. And why do some people have worse outcomes than others?
Mm-hmm. Yeah. Well, to start off with, all the patients who have Cushing's are different. Before Cushing's affects you. And I think that if you look around your family and friends, you will see that there are different attitudes towards life, different personalities. Some people are more optimistic, others are more pessimistic. And I think that that really does have a lot to do with how you overcome disease or how you overcome a problem in your life. Of course, there are some persons who have more problems, some patients who may have taken years for Cushing's to be diagnosed. There are some data now which seem to indicate that if you have been exposed to high levels of cortisol for a longer time, this does have an effect on the final outcome when you compare it with patients who have perhaps been diagnosed after a few weeks or a few months of having cortisol high. So that is definitely something which can affect outcome. And then, of course, also it depends at what age Cushing started, because it is most common, say, in young adults, 30 to 40-year-olds, but it can appear in adolescents or even in children, or even in older age, patients of 60, 70, or 80. And usually in these older patients, it's more difficult for them to adapt also because they are older and they are more prone to other complications just because of their age. So I think that Cushing's definitely has similar effects on everybody, but the body that suffers that Cushing, or the mind that suffers that Cushing, was different to start off with. And then, of course, the way that Cushing is dealt with, the information you get, the family support, the environment support you may have, obviously this may all affect your outcome positively.
And does the length of time that you go undiagnosed affect the outcome?
There are data now that seem to precisely indicate, yes, that is the case, that the longer that you have been with high cortisol, the worse, let's say. So the better, the shorter time it takes. The diagnostic delay is short, the outcome in the long run is better. Mm-hmm.
So I think I just sent you one last question, and I hope we can get it in the last few seconds here. It's kind of a long one.
Oh, you've just put another question?
Yeah.
Wait a minute. Okay, great. It should be at the bottom, right? Oh, it's not there yet.
Oh, okay. So let me just.
There we are. Whoops. The last one I can see is the one on pregnancy.
Okay, so the question here is, and this is specifically coming from someone who is a licensed mental health practitioner, and she asked, have you come across any use of the alpha stim in the treatment of depression, anxiety, and sleep disorders?
alpha stim. I'm not quite sure what that means.
Okay, and then have you heard of any mental health practitioners using EMDR, eye movement desensitization processing for anxiety and trauma-like symptoms?
I'm afraid I haven't.
Okay. Um, so thank you so much. And I sincerely appreciate all the time that you've spent. And thank you, everyone, for participating. So many thanks to you, Susan, for joining us and
My
spending your
pleasure.
Saturday evening. And thank you also to our sponsor, Strongbridge Biopharma. And many people have asked, we are recording this and we will post it on our website for everybody to view and share with their family after we're done. So thank you, everyone.
Thank you very much.
All right. Bye-bye, everyone.
Bye-bye.